So let me tell you a little bit about how I came to chronic pain. You know, I started at the time there really wasn't mind body. It was really in its infancy, and I was working with a number of people, and especially as I in the 70s developed somatic experiencing. In a way, I was very fortunate. In some ways, I was unfortunate, but I was also quite fortunate. And the definition of trauma as PTSD hadn't yet occurred until like it was 1981. So I didn't know, thankfully, well, a couple of things. I didn't know that trauma was supposedly an incurable brain disorder, incurable brain disease, even that couldn't be cured, but at best could be controlled with drugs, with medication, and with helping people change their negative thoughts. So what I discovered is that trauma is by the way, I want to make clear that I'm not anti-medication. Often medication can be helpful, can even be life-saving, but it's never a solution. It's never a complete solution, at least so far as we know. Anyhow, what I observed is that trauma is something that happens specifically in the body. So our guts tighten up, our jaws are clenched, our shoulders are tight. This is the way that trauma is replaying in the body. And it's also the way chronic pain can be an important component of trauma. So in other words, I was working with these people during that time. And very often when they would talk about, what their symptoms were, it was in many cases, it was chronic pain. And at that time, the definition hadn't been made yet. Also, the fibromyalgia, chronic fatigue, irritable bowel, all of these physical things that happen in the body and that go beyond the PTSD, and that are also rooted in trauma. And really, that's the key. So let's see. I'm now shared my screen, and okay. So we're working with the chronic pain connection, somatization, and chronic pain. And a little bit of a side excursion here. Rene Descartes, and this was in the 1600s, and he was really a great thinker at the time, but he got things really wrong fundamentally. And he really talked about what now is known as a mind-body dualism. There is no connection with mind and body. They're separate entities. And we've really gotten stuck with this legacy. And does the fish know it's in water? And I think it's really something that's there in disembodiment. And one of the reasons I enjoy talking to this group, is that isn't it called the Embodied Lab? I think so. And that is our laboratory to really explore our bodies, our anatomical, physiological bodies, but primarily our living, sensing, knowing bodies. And this is just one of the paintings from the Belgian surrealistic painter René Magritte. And you see again that separation between mind, brain, and body. And when the body is in such a difficult state, talking is not going to help the situation. And so you see here, the analyst is taking his notes, and the patient is there, and his body is in quite a mess. And he says to the patient, "We'll soon have you sorted out, Mr. Fenton." And again, this is why talking is important. It's important, as we'll see, that's top down, but it really doesn't touch the deeper layer where the body fragments, where the body dissociates, where the body gets gripped in chronic pain. So just a very brief, what is trauma? And it's an event which overwhelms the brain and the body, and is too much for the autonomic system to handle. And so it overloads and it goes into an adaptive state, and that adaptive state is very likely to be the cause of chronic pain. And I think this is from my book, Trauma and Memory. Yeah, it is. When a person is exposed to overwhelming stress, threat, or injury, they develop a procedural memory, sometimes called a body memory. And trauma occurs, as well as pain, when these implicit procedures are not neutralized. And the failure to restore homeostasis or balance, core balance, is at the basis for the maladaptive and debilitating symptoms of trauma. Yeah. And here are some of the physical effects that can occur with unresolved stress and trauma, with unresolved toxic stress and trauma. And there are common physical disorders, which can include, as I mentioned, gastrointestinal, particularly irritable bowel, cardiovascular, arrhythmias, and so forth, neurological, things like migraines, musculoskeletal, like fibromyalgia, respiratory, like asthma, dermatological, urological, and substance abuse disorders are very common. And substance disorders as a way to try to help manage these unbearable feelings and sensations, and to just tamp them down just once, to leave people to contribute to a life of misery for that moment. And again, the only way, I believe, that one can change the substance abuse is by helping the person find ways to healthily regulate, adaptively to regulate. And that's what we'll be talking about a lot. And again, just giving a quick overview about unresolved trauma, what it can affect: depression, anxiety, chronic stress, chronic pain, PTSD, heightened states of fear, rage, chronic insomnia, even paranoia, dissociation, shutdown, isolation. We talked about addiction, and suicidal ideation, emotional suppression, lethargy. Along with lethargy, I would also add something like alexithymia, and bracing patterns, and I'm repeating myself, IBS, irritable bowel syndrome, and other digestive issues. And the list goes on and on and on. And it's, when somebody presents with those kind of physical symptoms, I always, especially if the symptoms don't shift quickly, in doing therapy, I really advise them to see a physician to have evaluated. Now, the converse is that many of the people have gone from doctor to doctor, specialist to specialist, with no cause found, and with not much treatment. We'll come back to that. So this is the iceberg, the giant iceberg. On the top where I say explicit memory, what I should really say there is trauma symptoms like PTSD, like flashbacks, like hypervigilance, where the majority, I mean, the great majority of this iceberg, this is the iceberg that sunk the Titanic, are made of implicit memories, procedural memories, somatization or somatic dissociation. Shame is also a really big component in this subterranean iceberg. And again, it's when we see the person just with these very specific PTSD symptoms, we should know that that's possibly just PTSD, but it's also very likely that there's this whole underbelly, and that we have to work somatically with that. Yeah. Okay. Now this is a cross section. I think I showed this in an earlier webinar I did with you, but it's definitely necessary to review. And if you cut my brain and body in half, and then took one half away, and you're looking at that half, that's sometimes called the mid-sagittal view. And this area right in here is absolutely critical for everything. It really controls all of our instincts, all of our regulation. And then this other part, which is very closely allied with the brain stem, is the cerebellum. And the cerebellum, people used to, researchers used to, if you went to a physiology book at the time and went to the entry for the cerebellum, and it would say the cerebellum, the function of the cerebellum is to regulate movement. And that's true, there's no question about it. And by the way, usually there's maybe one or two paragraphs, and basically about the anatomy. And it became clear to me in my work that the cerebellum and the brainstem together were the matrix, the foundation upon which all of our sensations and emotions and feelings and thoughts are built upon. And now, starting from about 15 years ago, if you can go into the medical library, and there's a book this big about the cerebellum, and it literally connects to every part of the brain. It's evoked by movement and body sensory information, particularly kinesthetic, muscle tension information, and proprioceptive, where the body is in space. Also by movement and by acceleration for the vestibular system. And there are three main systems. There's at the back of the brainstem, and that dorsal just means back, is the 10th cranial nerve. And this nerve here goes, very primitive nerve. It's one of the most primitive nerves in the body, but it's also the biggest nerve and the largest nerve in the body. So here's the vagus nerve, the 10th cranial nerve. That nerve goes down through the neck, down all the way to the organs below the diaphragm, but also it affects the heart and the lungs. And what has not widely been known, and if you even go to many current physiological texts, it says that it's a motor nerve. In other words, it's activating, instead of muscles, it's activating organs. But there's very little reference to the fact that it's also a sensory nerve. So it's actually relaying information about our guts and our other organs to the brain. So it's a way of connecting to to monitor our internal state and to know when we're in balance and to know when we're out of balance. And again, 80 to 90% of that nerve is sensory, is taking information from the guts and relaying it back up to the brain. So let me give you an example about this connection. And if it feels like it's too much, just ignore it. Yeah. But imagine you're opening your door and looking out on the street, and all of a sudden you see somebody hit by a car. Well, the vagus nerve recognizes injury. The brainstem recognizes injury and sends a strong signal down to our guts. And so we see the injury and we go, oh. But since that nerve, remember, 80% is sensory, it's taking that yuck signal back up through the vagus nerve, the sensory portion of the vagus nerve, back into the brainstem where it gets amplified. So you're there, you see the accident, you go, ugh, and then you can see the person's really been seriously injured, and it's like, ugh, and we can get stuck there. And that's one of the components we see in chronic pain. Now, what I'm going to invite you to do is do a little experiment to see how we can regulate that nerve when it's been thrown out of balance. So again, when we have the image of the injury that goes down the vagus nerve, affects our inner organs, gets amplified, and we get into this, what I call a positive feedback loop with negative consequences. So it amplifies, and then guess what? After it's been amplified many times or multiple times, or maybe even one or two times, we then start to have gastrointestinal systems or heart arrhythmias. So here's an exercise that I'm going to offer. Again, if it feels like it's too much, just watch me and listen to me. But of course, you're welcome to do the exercise along with me. So the idea here is to interrupt that positive feedback loop with negative consequences. And the idea in this exercise is to make the sound boo with the breath, vibrating it. That's why I specifically use that sound. And I let the breath and the sound go all the way out, and then just wait for the new breath to come in, filling belly and then chest. So let me just demonstrate it. I'll do it a couple of times, and then you can do it with me if you want. When I feel the vibration in many parts of my body, but specifically in the guts, the viscera. And I wait for the breath to come in on its own, filling belly and chest, and then one more time. Okay. So again, if you wish to do it with me, please do it. And just notice sensations, feelings, images that may come up, thoughts that may come up, and not necessary to linger on them, but just to make a note of them. And then maybe you can take a moments to give feedback. So, okay, so let's do it together. Okay, easy, full breath. And just notice. Again, sensations, feelings, thoughts that come up, images, total calm, soothing, warm sensation, shivers on back and goosebumps. Yes, I feel like a kid coming to me directly. Emotions arising. Yeah. And again, just to notice the emotions. You don't have to do anything with it, but just to notice. Softening and opening, my eyes relax, vibration in my chest tickles a little. Yeah, and you can see many, many, many different sensations and feelings that are mediated by that vagus nerve. Interestingly enough, gurgle, yeah, that's right, iceberg melting in my sinuses, or melting, yes, okay. And again, you see, it's opened so many sensations, so many feelings, and it's a very, I mean, basically, this exercise took literally 1 or 2 minutes, and just from doing that exercise, there can be a profound shift out of what we'll be discussing soon about shutdown, and again, calmness and being present, relaxation in the lower body, and it goes on and on. Okay, so let's go back to my illustration here. Now, there are 3 other main state systems. In the middle of the brainstem is the reticular activating system. And this, when it's highly activated, gives rise to the sympathetic system of fight and flight. And then in the front vagus system, a different vagus system called the ventrovagal system. And interestingly, that system, again, some of you may already know this, goes directly to the muscles of the throat, the larynx and the pharynx. It goes to the middle ear, and it goes to the face, particularly the upper part of the face. You know, in real estate, there's an expression of the value of a property, and it's, maybe you know this already, it's location, 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 location. So why are these connected? There has to be a reason for this. And this is really Stephen Porget's brilliant and sweeping theory of the polyvagal system, the polyvagal. And so again, what is the value of connecting the throat? So when I'm talking to you right now, yes, I'm giving you information, but I'm also giving you some sense of feeling or aliveness or vitality. And that's in my voice. That's the rhythm of my voice. That's sometimes called prosody. And without that, we don't connect with another person. Because if I haven't seen you for a long time, and now I see you, I meet you on the street, and it's so nice to see you, your friend is going to just be, whoa, what's going on here? So we have to really connect with each other through our voices, through our sensory modulation of our and sensory modulation and motor control of our larynx and pharynx. The middle ear is what tunes the frequencies that we hear, that we receive, and this particularly is tuned for the healthy dimension, is tuned to the range of the human voice, particularly about the first voice that we are likely to hear as newborns. And that is, of course, or very often is our mother's voice. So again, and then our eyes, again, when we see somebody, we're taking them in. So these are all important functions on their own, but also about buffering against chronic pain. And the chronic pain it comes from a combination of the reticular activating system and the dorsal-vagal nucleus. And this is actually this is from a student of mine, and it's a nice diagram. And what it shows you is that this area in here of moderate arousal is what Stephen Porges called the neuroception of safety. So in other words, the environment is perceived to be safe. We have, we're playful, we have freedom, we have contact with chosen others. And then as the arousal increases, we start to perceive threat. And that's the fight or flight system. If this does not resolve the situation, right, this is the sympathetic system. And again, the sympathetic system is about controlling the muscles and tightening the muscles and readying the muscles for action. But if we don't have action, the muscles, so to speak, are all dressed up, but with nowhere to go. So again, you can imagine the tension increasing in your body, in your shoulders, in your neck, in your jaws, in your throat, and any and everywhere. You start getting symptoms again of chronic pain. Then, as this arousal goes even higher, it goes to an opposite reaction, and that is of overwhelm. And this is mediated primarily through the dorsal vagal system, through that shutdown system. So this is about freezing, collapsing, fainting, feigning death, and dissociation, fragmentation, and dissociation. What else I want to say about that? Yes, sometimes we're affected by the dorsal-vagal system, on its own. So, for example, when we see blood and the accident that I just described, some people actually faint at the sight of blood. It's not that uncommon, and that's just the dorsal vagal system coming into activation. But at the same time, we often have a combination or flipping back and forth between threat, sympathetic system, and shutdown dorsal vagal system. And so when a person is stuck up here, we have to find ways to help them regulate and downregulate. And one of the ways you just experienced was with the VU exercise. And it really, you can see that it helps access these feelings of safety, of goodness, of tingling, of vitality, of warmth in the belly. All of those things are about the neuroception of safety. And this is a bottom-up process. This is not something that you control with your mind. It's something that happens in the body and in the nervous system. And somatic experiencing is a bottom-up system. That's not to negate the importance of top-down cognitive restructuring, cognitive processing kinds of things. They're very, very helpful, and I'm a fan of them. But again, alone, when you're dealing with trauma, and especially with physical pain, you really need to work with the roots of the chronic pain in the autonomic and musculoskeletal system. Oh, this is just a little reminder that we don't have to know the facts of the story of where our symptoms came from. What we need to know is where they are in the body, how they're regulated, or I should say dysregulated, by the autonomic nervous system. So here's the just a visual of the systems, the system in the middle here is the healthy regulated range, primarily the ventral vagal system. Here, hyperarousal is the sympathetic system. And then shutdown, hypoarousal, again, is the dorsovagal system. But this is the area, this range in here is adaptive self-regulation. So we may go up and increase our activation, but then we regulate the activation, we down-regulate. And so there's this kind of nice swinging through the day of what I call relaxed alertness. We're alert, but we're at the same time we're relaxed. But it's not like we're spaced out. It's not like we're zoned out. It's like we're here and now. In a way, trauma is a disorder of not being able to be in the here and now. So in dysregulation of the autonomic nervous system and chronic pain, we see a swinging often between into hyperarousal. Then from the hyperarousal, we shut down into the hypoarousal states, then shoot back up to the hyperarousal, and so this goes on, sometimes within a matter of moments, or sometimes through a day, or sometimes for weeks or even months, as you see, arguably in kind of bipolar type disorders. So what we need to do is help the person regulate their arousal states. So instead of going way, way high into hyperarousal, yes, they're in hyperarousal, that increases a little bit, and then it can downregulate, and it touches into the hypoarousal, but it doesn't get stuck there, and it keeps moving. And then finally, we're to self-regulation. And or relaxed alertness. So again, let's kind of look at some of the chronic pain syndromes. Okay, this is a study from Kaiser Health, and they observed that up to 70 and even 90% of all primary care visits are driven by so-called psychological factors. And I add that the majority are for unexplained pain, chronic pain. And I would prefer this, instead of saying psychological factors, I would say something like factors like dysregulation, core dysregulation of the two systems of the sympathetic and the dorsovagal system. And they're not psychological. They really aren't. I mean, they have psychological components, but they're much, much deeper. And again, that's where we have to go to the bottom-up processing. But think about this. Even if it's 70% of all primary care visits, what a waste in terms of medical dollars that are spent dealing with chronic pain, usually with little or no effect. And the drugs for chronic pain, of course, have their own serious problems, such as, for example, opioid addiction, but also just in terms of lost productivity and of the distress that the person is. Pain, horrible pain, is scary. It's really, it's a load. It's frightening. It's scary, especially when we can't find out its cause. And for most of these individuals, the treatments are ineffective. That's again also through that same Kaiser study. Okay, there actually is a symptom or an explanation. I'm going to put that in quotes, a quote explanation for these pain syndromes, and they're called MUS. medically explained pain symptoms, medically explained symptoms. Okay, why are you going to go with a diagnosis like that? Really? I think that's more frustrating than just saying I don't have a diagnosis. The diagnosis is we don't know. It's medically unexplained. And you can imagine somebody who's been, struggling with pain, like fibromyalgia, with irritable bowel, with migraines and so forth, and they get the diagnosis, it's medically unexplained. I think it's not really pejorative, but it's certainly not helpful. And again, in all parts of our healthcare system, we meet patients presenting with physical symptoms that lack an obvious or organic basis. Let me just mention the studies done by Fileti and Andrus, the ACE studies. A stands for adverse, C childhood, E experience. And children, there are 10 questions, and if you answer yes for 3 or more of these questions, in other words, there was alcohol or drug use in the family, parent went to prison, yelling and screaming in the household. These not so uncommon things. If you just have 3 or more of these, not only you're likely to have physical symptoms, but you're also along the line also very likely to have symptoms of actual disease. So in other words, people who have had early childhood trauma are way more likely to have diabetes, to have asthma, to have, of course, suicidal thoughts and anxiety and depression. But these actual quite organic illnesses. And so again, you're looking at the consequences on trauma, unresolved trauma, and particularly pain. It's enormous cost. It costs billions of dollars per year in treating non-productively people with these symptoms. And I hope that somehow my work over the years has contributed at least offering some functional and physiological avenues for exploring the cause of these pain symptoms and also physical symptoms. Well, we did that. Okay. Yes, again, I want to remind you that these physical symptoms are the majority of the impact that people with trauma have in their bodies. Yes. Oh, yes. Now, this part of the body of the iceberg got the definition of desno. So they tried. The people who were working in the field tried to get this early chronic developmental attachment trauma into the DSM-5 unsuccessfully. Not sure why, I can theorize. And so they call them disease of extreme stress, otherwise specified. And they got the name desnos disorders, extreme E, D, S, stress, O, otherwise specified, desnos. So again, if we look at this is the area of desnos. So these are the physical sensations and physical pain syndromes and illnesses that come from chronic trauma. And people with these kind of presentations, the desnos, they have alterations in regulating their emotions, affect regulation, states of consciousness shift rapidly. Their self-perception is distorted. See, that's a lot with anorexia. Their relationships to others are compromised again because the ventral vagal system is not really operative, so you can't make contact. You can't establish a relationship when you're in the fight or flight or the shutdown system. the dorsal vagal system. So relationships with others becomes extremely limited. We have systems of meaning, in other words, trying to explain to ourselves what's happening, and specifically somatization syndromes in chronic pain. Okay, so self-regulation is then the organic physiological basis of trust, security, and goodness, of approaching and exploring. So in other words, we're at a party and we're introduced to somebody. We may be just drawn to just to see, wow, that's interesting. You know, you remind me of somebody else or whatever it is. You're just, you know, you're kind of feeling things out. You're checking things out. When we're in the trauma states, the dorsal vagal and the sympathetic system, something about them, a smell or a gesture or a posture, all of a sudden you're feeling fear or rage. I mean, where did that come from? Okay, well, it came from, you know, from something long time ago that made it impossible to really select if this is a person that I want to connect with, because they immediately become the perpetrator that had affected me many decades before. And here are some basic causes of chronic pain. Of course, the somatoform conversion, the somatic dissociation, that's a term that my very dear friend passed away this last year, Bob Scare, wrote in two of his books. Very interesting person. He called these pain syndromes, which tend to migrate around the body. And that's another reason why people can be dismissed when they're being seen by a physician, because one day they're coming in and they have TMJ problem, then the next time they're having pain in the knee, then another time pain in the neck. And so often the physician thinks that these people are just doing this to garner attention, because it just doesn't make sense, you know, why it would be in one place of the body and then in another place the next week, so forth. But there are other causes. Well, the bracing pattern can result in chronic pain, as well as suppressed emotions. Emotions are very powerful, and when we suppress them, our bodies tighten against them, and that's similar to bracing patterns. So again, let's just say that we're in a, let me stop sharing here. Okay, so we're driving in our car and we stop at a stop sign and somebody hits us. It doesn't have to be going that fast. And all of a sudden our bodies go like this. Well, you know, we get the person's license, but it's kind of interesting. We're really feeling like we're really moving. That's the sympathetic nervous system. That's the fight or flight. We also don't feel pain because of the dissociation mediated by the dorsovagal system. However, the next day, we start having back and neck pain. We may go to the chiropractor, and the chiropractor makes an adjustment of the vertebra. With some people that can be helpful, but with other people, it's just like the whiplash happening again. So you have to really gently complete those responses. So instead of just being locked in this state of bracing, you find out, okay, it wants to continue in a movement like this, and then an easy breath often comes. So it's bracing patterns, and again, bracing against powerful, difficult emotions. And the thing about powerful emotions is, let's just say this is the emotion that's starting to come up, and we don't want to deal with that emotion, and so we suppress it. But because we suppress it, it pushes up even more, and then we have to push down even more. And then it seems like if we ever feel this emotion, it'll destroy us. But really, the emotion itself isn't destroying, it's the bracing against the emotion. That's the problem. Maybe I take just a few questions now, and then I'll do a little bit more speaking. But yeah, let's just take a few questions now.
So Peter, one that I have here, I'm just going to read it exactly how it is. Checking my understanding of bipolar. People don't become bipolar due to trauma, but trauma survivors can also have bipolar, ?
Yes, yes, that's right. I mean, of course, there are many, many factors for any kind of disorder. And, some may be genetic, but I really believe that the majority of them are chronic stress related. And, I think the rapid cycling where the person just goes from shutdown to hyperarousal, then to shutdown, that's clearly dysregulation of the autonomic system and trauma related. But the bipolar that goes over a longer period of time, I think is multifactorial. But I do think that stress is a component, a significant component, that is to say chronic stress. And again, the shifting between dominance of the sympathetic system and of the dorsal vagal shutdown system. So my answer there is yes, but with clarifications.
Okay. Okay, so Peter, what do you believe the interconnection is between hypochondria and chronic pain? And how can we help clients return to their body when they are convinced something is biologically wrong?
Yeah, right. Not by confronting it directly, that's certainly not going to help. But by doing the kinds of things that, we just did, with the boo sound and with like bracing patterns. So for example, many people carry excessive tension in their shoulders. And again, that's a bracing pattern. So when they become aware, well, they're feeling the pain in the shoulders. So I might help the person see if they can explore the muscular tension that's below the pain. So, okay, I can feel the tension, the client can feel the tension. So now just noticing what might happen to your shoulders if you actually increase the tension just a little bit. So I'm going to go like this, but I'm going to do it very slowly. Very slowly. So I just let it rise just a teeny bit, and then I let it release. I invite you, let's just do this together, everyone that wants to, okay? So again, feeling tension in your shoulders, noticing how your shoulders might move, probably up toward your ears, but just doing that in the smallest amount at a time. So letting the shoulders increase just a little bit, and then releasing them. And noticing sensations, feelings, images, thoughts. Again, just let the shoulders become a little bit higher, raise a little bit higher with the tension, and releasing and letting the shoulders drift down, settle down. Again, this may bring up different feelings, different emotions. It very likely is, because again, remember, we're bracing against physical impact, but we're also bracing against strong emotions, strong feelings. So again, to work bottom up, is of course where you do need to go. But some people, it's true, they have been reinforced that there's something wrong with them. I've worked with a number of people who has children. Their parents, usually the mother, takes them from doctor to doctor, and they then start to believe that they have an illness. And this is actually called Munchausen syndrome by proxy, Munchausen symptom is when people have these psychosomatic illnesses, so-called psychosomatic illnesses, and they go from doctor to doctor to try to get a diagnosis or a treatment. Again, many of the people are doing this presumably or arguably to garner attention. I think that is an important component. But then some of the parents will take the child from doctor to doctor, and the child starts to believe that they have the illness. And again, that's Munchausen by proxy. So, so again, to work with how the pain is being presented in the body is a way to get around those psychosomatic identifications. Okay.
Great, Peter. So many people with chronic pain adapt to not feeling. And someone is saying that when they try to work with them, they either become numb, they think they can't do it, or they feel more pain as they are drawn to the pain sensation. I'm not sure. So, Peter, I'm not sure if you touched on pendulation at all,
Yeah,
but
I did.
when they feel more pain, yeah, because they start to become real conscious of it.
Yeah, exactly. Again, remember that often with chronic pain, you have dissociation, and numbness is a somatic component of dissociation. And when the person feels, often the person will ask them what they're noticing, what they're feeling, they'll say nothing. Well, is nothing like, does it feel like it's numb? Yeah, oh yeah, it feels like it's numb. So that is getting at underneath that dissociation. Yeah. And it frequently happens, for example, the exercise I just did, when you have the shoulders go to the bracing pattern and releasing, while they're actually tightening, the pain is likely to feel worse. But the thing is, when you guide the person, then they can move into the tension, the pain and the tension, and then swing out of the pain and the intention. And so what happens is when we first start to feel these sensations, because if we've been numb for a long, long time, and we first start to feel them, it feels worse, but it really primarily feels worse because we have been disconnected for so long. But if we can help guide the person into that pain or tension just a little bit, and then help guide them out into an expansion, and then again into a contraction, and then again into an expansion, and again into contraction, and into a greater expansion. So it's a matter of titrating, of just doing it enough, but not too much, not overwhelming the system, not overwhelming the person. And you find that the natural response is through a rhythm of contraction and expansion, contraction and greater expansion, contraction and even greater expansion. So that's a really key concept in somatic experience, a dual concept: titration, one small amount at a time, and pendulation, the shifting between states of contraction and expansion. So again, with the shoulder pain, you are actually increasing the tension, but just a minuscule amount, titration, and then very slowly letting the shoulders come to rest. And notice what happens. Again, there may be a spontaneous breath. There may be some association with the pain in the form of an image or of a thought, etc. But again, we're working bottom up, and that's critical. Okay, so maybe I take one more question and then I'll continue, and then I can take maybe questions at the end.
Okay, Peter, we have a few on the connection between chronic pain and more, and then pretty general too, the social impacts of trauma, when there's a societal trauma, and any associations with chronic pain, and mainly like kind of how to connect to that and the different types of trauma you may have.
So it's a little bit of a different question, but social trauma, it's when groups of people are traumatized. And you see this in natural disasters, but of course you see it in the aftermath of kind of things that are going on right now. It's heartbreak, truly heartbreak, deeply, deeply sad, especially if you know something about trauma, the effect that this war is having on the population. It's just horrendous. It's really, really horrendous. One of the things that we're doing is we've my co-author Maggie Klein and I put together a booklet from a book on giving parents and teachers education on what to notice with children when they start to present with symptoms like chronic pain and PTSD. So, and again, if everybody is experiencing this dread and fear, that gets communicated. It really gets communicated. When you're in a state, when somebody's anxious in a room, you may not even see the person or notice the person consciously, but all of a sudden you start feeling anxiety. So think about that when you have a whole population of people who are experiencing profound anxiety, and then they're just reinforcing that, and it goes and over circulates. And of course, the same thing is true with chronic pain that is trauma related. Okay, so let me go on here and we can take a couple of questions. They're all interesting questions. I think I had a few final things I wanted to share with you. So this is review, really review, but it is worth review because it is really what this program is about. Okay, so what are some of the antecedents of chronic pain? Well, the continuation of acute pain that's not adequately treated. And it's really a problematic thing that, because opioids were so abused, that many physicians are reticent to prescribe opioids for high levels of even of chronic acute pain. And so because the pain is not treated, it continues and then can become chronic. So essential to use the right pain medication for acute pain so that the acute pain isn't there. You blunt it sufficiently. And that's what's, exactly. And then it just becomes, there were some studies done. My brother, who's one of the world's authorities on chronic pain, the psychophysiology of chronic pain, and that really, if you want to set up the conditions for chronic pain, don't adequately treat the pain with the opioids, that's the population that's likely to become addicted because the pain wasn't adequately treated. And again, adequately treated means that the pain level goes down to a tolerable, at maximum a tolerable level. So we have, again, fear, bracing, increased pain, more fear, more bracing. That's that repetitive cycle. Then the facilitation at multiple levels in the brain is kind of interesting. This is very, very interesting, that the areas in the brain that register emotions also register chronic pain. So again, chronic pain and emotions are organized together. And I think that's one of the reasons why chronic pain is so tied to emotional states. Okay, how does acute injury become chronic, and how does chronic pain lead to more complex disorders? Yeah, so, okay, so let's just say you have a bracing pattern like this. So I have the bracing pattern in my shoulder. I don't resolve it. I don't even notice it really. You know, I feel a little bit something is not right, but yeah. So I just carry this around for hours, days, weeks, months. And what's going to happen, the pain is going to increase, and other muscles are also going to be recruited to tense, to become tense. So when this is here for a while, I have pain in my shoulder, but then I also am having pain in my neck and in my jaw. Then I may be having pain here in my chest. Now, fibromyalgia is diagnosed by having tender points, in a certain number of areas in the body. I think it's 13 bilateral points, so that's 26 points. But it's an arbitrary, because what happens if you only have 12? Well, you don't have fibromyalgia, but you have chronic pain. So you see that really fibromyalgia is a devolution of pain, and the pain spreading to different parts of the body. And the mechanisms by which they spread is actually pretty well known. It's been known since the early 1900s. The work of Charles Sherrington, who won the Nobel Prize, and he studied what was called facilitation. So if you continue to injure a part of the body, the parts of the nervous system that are impacted increases and increases and increases and spreads, and eventually can spread to the whole body. The turtle reflex is sort of what I was getting at. So again, it may start with the shoulders, but in protection, the shoulders go up and the neck goes down, very much like the reflex that a turtle does. So when a turtle is exposed to threat, and it just goes like this, it stays in its shell, but it knows how to come out. So again, what happens with us is we get stuck here and we don't know how to get out. Okay, so again, let's practice, if you wish, this turtle reflex exercise. So again, shoulders are going up, neck is shortening, and as though your head was being pulled into a shell, and then feeling that, but just doing it a little bit at a time. So again, just feeling a little bit of the turtle, and now imagine it's safe enough and you come out of the turtle, out of the shell. And again, come into the turtle a little bit more this time. Gently titrated, and then slowly coming back out. And just doing that a few times can very often greatly reduce the pain. All right, so, and again, always gently, less is more. Oh, okay, so these are things that I haven't mentioned, but I think this could be a good review. Okay, somatization can be a defense mechanism against emotions. Of course, it can also be related to trauma, the fight and flight, or the collapse. And that the areas in the brain activated for physical and emotional pain are almost identical. Also, many of these same areas are areas that register sensation, particularly areas in the insula and the cingulate. And my theory is that what we need to do is to have sensations that are contradictory to pain, that contradict those of pain, because those also are occurring in the same areas. So when the person, for example, is able to feel the sensations underneath the pain, that in itself has a profound effect often in regulating the pain, whether it's physical or emotional. And again, in infancy, there's a low tolerance to physiological stress. So the infant that needs to be picked up and held and soothed, that's cold, an infant can't put on a sweater or even a blanket. The parent, the caregiver, has to help them regulate. And so that's essential to develop a capacity to self-regulate. So to co-regulate, to learn to co-regulate first, and then to begin to learn how to self-regulate. Okay, so again, emotional suppression and repression. And this is another one that I haven't mentioned. It is worth mentioning, is that that there's a tendency of society to deny suffering, particularly grief. We don't, as a society, we don't do very well with grief. And this has been a time when there's a tremendous amount of grief. Many people have sadly lost loved ones, or may have experienced, COVID themselves. And certainly many of us, most of us, maybe all of us, our lives have been altered. Things that were meaningful to us, like meeting at a restaurant with a friend or friends, we've had to give those up for some years. Years. And so there's loss from that, and that grief and loss just tends to perpetuate itself. And, and in the US for sure, it's somewhat like this also in some of the European countries, but especially in the US, we're not supposed to feel grief, because grief is listed as a weakness. And so if we equate grief and sadness with weakness, then we're going to avoid it at all costs, and it's going to accumulate. And again, grief that doesn't get felt and expressed and explored, again, often can lead to chronic pain. And also the denial of the validity of pain by physicians or other healthcare providers can also be traumatizing. So again, if the person who has chronic pain, and pain that doesn't seem to have an organic cause, and physicians feel frustrated. They want to help people. That's one of the reasons they, selected that occupation. But then when the medical said, well, it's just all in your head, that then reinforces the trauma and the pain. Yeah, and this is, I've talked about this, but here it extends a little bit. Okay, so trauma as hyperarousal becomes abound usually in muscular symptoms of readiness to flee, to fight. And over time, usually, hypoarousal takes over and then may predominate, and then experience numbness, dissociation, lack of energy. And without discharge and regulation, and with continued accumulated stress, the symptoms then bind into constellations. Again, so you start with tension in the shoulders, and then you start, and you have then tension all over the body. That's a constellation. So without regulating the stress, without discharging the stress, it will go more and more into constellations and probably even to things like autoimmune conditions. And as these patterns solidify, they organize into those syndromes. And syndromes frequently have a protean and mercurial properties. In other words, they migrate around the body, and they have complex autonomic presentations. So again, when we're able to work physiologically, bottom-up processing, I think that's really the should be the gold standard of working with unexplained chronic pain. Okay, so I think maybe I take questions now. Yes. Yeah. Okay. So we've done, I think so. Yeah. Let me just take some questions because this is again kind of, yeah. Yeah. Okay.
All right, Peter.
Yeah.
Okay, so Peter, I do know a lot of yoga teachers take the IC training, but someone's asking, can movement interventions like yoga, specifically gentle or yin yoga, help unlock bracing patterns, or is this too aggressive of an approach for chronic pain?
Yes, the underscore here is gentle. And, you know, a number, I mean, we've trained, I don't know how many hundreds or thousands of people who are like yoga teachers or movement therapists. And yeah, I mean, absolutely, especially if the yoga teacher has some understanding of how trauma gets locked in the body, and that also there's not too many people in the class because often the person will need some kind of individual attention when they come to a bracing pattern, because if it's possible that the person will go into it too quickly, so that it increases too quickly. So again, the yoga teacher has to be aware of that and be ready to intervene with the person. But absolutely, people who do movement work, who do yoga, as I say, one of the things about somatic experiencing, it's not a therapy per se. It really is about how people do what they do. So of course, it's for psychotherapists, psychologists, and so forth, but it's also for people who work with the body, because again, the idea is however their profession is, to tune it to a higher level, you know, is more than desirable. So anyhow, the short answer is yes, yoga gently and trauma informed can be very helpful in working with bracing patterns. Very, very, very important.
And Peter, how do you work with inflammation? Is there anything specific or different?
That's a good question. You know, I think there's good indication that systemic inflammation is a component of trauma. You know, it's interesting. Stephen Porges is doing a study on this, that people who have had childhood trauma, significant childhood trauma, are more likely to have severe reactions to COVID. And I think a big part of the reason for that is that you have this inflammatory states, which again is what some of the effects that the COVID virus causes. So I think, yeah, I think inflammation is a really big component. I mean, there are different things I think that may be helpful, like different kind of supplements to some degree. But really, I think the main cause of systemic inflammation is trauma related. And again, going back to the ACE studies, that so many of these illnesses that people develop, like diabetes, like heart disease, I think also have components of systemic inflammation. Okay.
Okay, Peter.
Good question, important question, really.
Yeah, it's kind of a one I haven't heard come up
Yep, that's a very good question. Very important question.
So, Peter, a lot of times in the medical system, there's racial disparities where Black bodies are seen as not experiencing pain in the same way as white bodies. And what are your thoughts on how they may make progress in this area, as being an advocate for themselves and in both treatment and the outcomes?
Well, that's another, yeah. I mean, people of color clearly don't have access to the same medical systems that white people do. And it is underneath, it is a racial issue. It is also a racial issue. And I think physicians need education about some of those differences. And I think it's the questioner said, do people of color, are they more likely to be dismissed by physicians? And again, I think the answer there, unfortunately, is yes, there is some.
They know there is. It's statistically shown. It's very
Yes,
high.
yes,
So just trying to
exactly.
figure out how to maybe address that between your practitioner and maybe your therapist, or how do you?
Yeah. Well, again, if you're working with a person of color and they're presenting with symptoms like chronic pain, I think you have to kind of, again, you don't know, because certain pain could be due to actual physical abnormality, and so you have to kind of help the person stand up for themselves and say, look, to their physician, I need you to tell me if this is something that's structural or if this is something that's functional. You don't use those words, but that's really what it's about. To stand up for themselves and say, look, what tests can you do to say whether this pain is due to something organic? As I said, I think a lot of this really has to come from the education system, where from the medical schools, to really have physicians, to help physicians really understand and acknowledge their own biases and to work with them. I mean, I have to tell you personally, I'm sometimes shocked with my biases. I'll give you an example, and then I guess we'll get a little over time. I gave a talk once. This was a program set up by the mayor of LA, and it was with group of people, therapists and law enforcement people that work with or have the initial exposure to children that have been sex trafficked, and also not only children but adults have been self-trafficked. And afterwards, this Black woman came up to me and she said, is there a book that you would recommend? So I reached in to take Waking the Tiger, because that's the most simple, clear, for less technical. And while I was taking it out, we had a conversation, and she was in her mid-20s. She had a clinical psychology degree, and she was now in law school. And so I have to say, even if I talk about this, I'm really embarrassed about it. I said, you know what? You can keep that book too, but I'm going to give you some other books that are a little bit more technical. And so that, again, it's subtle how that plays out in not just in the healthcare, but in all of us. And I think we have to really look at that. A friend, colleague, who's also a somatic experiencing person, practitioner, Mencken, what's his name? Mencken. He wrote first a book called My Grandmother's Hands, really beautiful book. And he really talks about, using the somatic experiencing perspective of how people, are treated in society. So I think that is it here. Okay.
Okay.
Well, I would say, in summary, is that chronic pain is a complex phenomenon, and it has many causes. Some may be physical, structural. Others may be trauma-based. Others may be emotion-based. And so we want to really look with somebody who's presenting with chronic pain, what that pain might be. And it's important, it's really essential that therapists who have clients that have chronic pain are also working together with physicians, particularly, or maybe even other healthcare providers, but particularly with physicians, so that they can have a dialogue between the practitioner and the physician about each referral of clients that have chronic pain syndromes. So to develop a relationship is really, really important with physicians. I suggest also, if it's possible, to have a relationship with not only what do you call it? A family physician, a primary care physician, and others as well, because sometimes people present with things that seem to have a neurological component, like, for example, like trembling. And trembling may be the beginning of the body's wanting to discharge, but it also could be an illness. So again, if you have a primary care relationship, you have a neurological, gastrointestinal, because again, something could be wrong. If the person has irritable bowel, there could be something, there could be, who knows, a cancerous growth or something like that. So again, you want to work with a group of providers, especially physicians. Somebody asked about migraine. Unfortunately, I didn't have time to describe what I think goes on in migraine, but it is a interaction, I believe, between the sympathetic and the dorsal-vagal system. So you have constriction of the blood vessels in the head, and then an abrupt distension of those blood vessels. Anyhow, I shouldn't be giving you more stuff right now, but again, to make sure that the person has a proper assessment from a neurologist, and then work to help the person regulate. Good. Okay.
And Peter, real quick, we did have someone asking about a few times about spinal cord injuries, and I don't know if you want to mention the SE body workers or what to.
Yeah, I mean, spinal cord injuries. Often there's not a complete transection of the spinal cord. So if you can, again, find those inner movements, it's possible that you at least can improve the overall function and at least improve the autonomic function to some degree. Okay.
Thank you so much, Peter, and thank you, Melissa, for all your help. And thank you, everybody, for joining us today.
Okay, great. Okay.
Thank you.
Ciao for now. All right. Bye-bye, all.